So the Lovell study is a pretty straightforward one. It starts out with a discussion of the effects of OCD. They mention that the economic burden of the disorder is high, that the estimated direct and indirect costs are $8.4 million in the United States each year. And therefore, it would be really helpful if we could find a way to get treatment to people more quickly. The current mode, at least here in 2006, the writer says, the current mode of delivery is a 45 to 60 minute face-to-face session with the therapist each week during the hours of 9 a.m. to 5 p.m. This mode of delivery results in long waiting lists and precludes or prevents access to treatment. They had started to do computerized cognitive behavior therapy and facilitated self-help, but even those things still required you to occasionally attend scheduled clinic appointments. So the goal here was to find out if CBT carried out by telephone would be equivalent to face-to-face treatment. The hypothesis based on a pilot study and another study was that the outcomes would be similar for the two treatment methods. So this was a randomized controlled non-inferiority trial, and we'll take those one at a time. Randomized obviously refers to how the Ps were allocated to their groups. Controlled, the idea here is that one group received a control treatment. There was no control group. There was no group that received no treatment, but the face-to-face was the standard treatment for OCD. Then it's referred to as non-inferiority because that means neither group is expected to have a worse outcome. In a placebo-controlled trial, obviously, the placebo group is expected to have a worse outcome, but here, based on previous research, they expected that both groups, the outcomes would be similar for both groups. Here's a little breakdown of the sample. They include this helpful flow chart for us so we can see how exactly it went. These participants were recruited from 2 outpatient treatment units in Manchester. You can see that they were contacted from these referral letters. 91 were contacted. 5 of them refused to take part. Then the 86 who remained were assessed for their eligibility for the trial. We're going to come back to what would have had you decided eligible for the trial. Then 9 people were excluded based on that. And then the ones that met the inclusion trial were assessed, and they started that 1-month baseline period. Before starting trial, they were assessed twice with the Y-box. Once and then 4 weeks apart, and then 4 weeks later they were assessed again. So that was their baseline data before they ever started treatment. Of the ones that were, of the 86, of the 9 that were excluded, some reasons that they were excluded, 2 had suicidal intent, 1 had substance misuse, 4 had problems not connected with obsessive compulsive disorder, health anxiety, 2 with PTSD, and social phobia. So that was some reasons that people were excluded. There were, of that 77, 5 of them were lost. They did not return for the second baseline visit that 4 weeks later. So when they had finally completed the baseline period, they had 72. So they randomized those 72 participants into one of 2 interventions. You can see that they were, one of the criteria was you had to score at least a 16 on the Y-box. You may remember that the Y-box goes from 0 to 40. 16 to 23 is the range for moderate OCD. That 16 is they use that. That's the beginning of moderate. 24 to 31 is severe, and 32 to 40, which is the top of the range, it would be considered extreme. I'm going to have you look at the Y-box real quickly. Just so you remember how it looks. There's 10 questions. 1 to 5 is going to have to do with the obsessions. Remember, OCD is both obsessions and compulsions. Obsessions are unwanted ideas, images, or impulses that intrude on thinking against your wishes and your efforts to resist them. And then here we have some reminders of some common obsessions. So they answer this part. You can see that the first question has to do with how long is occupied by your obsessive thoughts. They're all on a 0 to 4 scale, so it's a 5-point scale. 5-point scale, 0 to 4. And you can see that the scale is different for each one because it has to do with different aspects of your obsessions. Then it gets into questions about the compulsions. As a reminder, compulsions are urges that people have to do something to lessen the feelings of anxiety or other discomfort. The reason that they do these things is to alleviate the anxiety caused by their obsessions. Repetitive, purposeful, intentional behaviors called rituals. Again, the point is that they are doing this for a reason. These are intentional because in some way, there's some link that suggests that there is some link in their mind between that obsession and that compulsion that alleviates it. The behavior may seem appropriate, but it becomes a ritual when done to excess. So, washing your hands, checking to make sure you lock the door, those are appropriate behaviors, but the scale is the issue here. I just let you glance at these. So the questions 6 through 10 on the same scale, but deal with those behaviors. So their mean score prior to treatment was 25. 16 was the minimum, 25 was the mean score of all the participants prior to treatment. That is in that severe, that's at the very beginning of that severe range. The way they were allocated to groups is using permuted blocks of 4. I learned my lesson by ignoring what a Latin square design was on North. So here is a permuted block of 4. What they would do is they would write down the 6 possible different sequences that include 2 A's and 2 B's, because if you've got 4 participants or 4 patients in a group, then you need to allocate 2 of them to face-to-face and 2 of them to telephone. So for some reason, they wrote down the 6 possible sequences, and then they assigned the first 4 patients. Then they just blocked the patients, and they assigned the first 4 patients to AA and BB. So patient 1 and 2 would go to telephone. Patient 3 and 4 would go to face-to-face. Then in our next 4 patients, the first 2 would go to face-to-face, and the next 2 would go to telephone. So this is what a permuted block randomization looks like. Like I mentioned, they had to have a Y box of 16 or higher. Some things that caused them to be excluded. If they had what's called obsessional slowness. Now, obsessional slowness is associated with OCD, but there's also a theory that it should be its own diagnosis and that it often occurs comorbidly with other disorders such as catatonia. So they excluded that. Organic brain disease, substance misuse, severe depression, or already on a stable dose of antidepressants or anxiolytics for less than 3 months. For a similar reason to previous studies we've looked at, we know that SSRIs are used to treat OCD. So if they have been on SSRIs for less than 3 months, then any result we see any outcome we see as a result of the treatment, we can't be sure if it was a result of the anxiolytic or the antidepressant, or if it was a result of the CBT, specifically the ERP that they were receiving, whether by telephone or face-to-face. I'm sorry, one more thing about permuted block that I wanted to read you. Randomization sheets were drawn up at the first baseline visit and kept by the principal investigator, so that's Lovell. Therapists randomized patients to treatment groups 4 weeks later after telephoning the principal investigator to obtain the treatment allocation. Researchers who were blinded to treatment allocation assessed patients at both of the baseline visits, the initial visit after treatment and at 1, 3, and 6 months of follow-up. So the principal investigator, Lovell, they created this list of things, and then the therapist called Lovell and said, okay, how do I assign them? And then they assigned them based on this criteria. But the people who were assessing the patients were a completely different set of people than they were blind to the patient's treatment condition or treatment status. So in that respect, it was blind. We can't say that it was double blind because obviously the patients knew which group they were assigned to. They knew whether they were receiving face-to-face or telephone CBT. The measures they were given, like we said, we mentioned the Y box. They were also given the Beck Depression Inventory and a client satisfaction questionnaire. So these are our measures that we have to compare. Procedurally, each patient received 10 weekly sessions. Those sessions were delivered by 2 trained, experienced cognitive behavioral therapists. They received fortnightly supervision, so every 2 weeks. And at that time, the notes, their patient notes were scrutinized, is what they tell us. It's another thing they point out about these people. It was 1 therapist at each location. Remember, they were recruited from 2 outpatient centers in Manchester. It was 1 therapist at each location that delivered both the face-to-face and the telephone treatments. And they went through training days every 4 months during the first year of the study. So it was only 10 weekly sessions, but the study went on for longer than that because they weren't obviously treating all 72 patients at once. So within that first year, they had these every 4 months training days because obviously they needed to make sure that the CBT that they were delivering was effective CBT. The progression of it, the first session for regardless of your condition, the first session was that psychoeducation. During that time, the researcher would explain, the therapist explained the rationale or reasoning for graded exposure and response prevention. Remember, the way that works is we endeavor to reduce the patient's anxious and fearful reactions through gradual, repeated exposure to those anxiety-producing situations. In collaboration with the patient, therapists use the assessment data to devise a hierarchy of fears. From this hierarchy, patients and therapists set weekly targets to be completed between sessions. The therapist encouraged the patient to progress through the hierarchy of fears by practicing their targets for at least 1 hour a day and monitoring their progress on a homework sheet. The therapist reviewed homework, helped devise weekly targets, encouraged the use of a co-therapist, such as a relative or friend, and helped to preempt any difficulties and solve problems. A crucial difference between the telephone and face-to-face conditions is that the telephone therapy, they did have the first session and the last session were face-to-face, and that covered the same material, same information as the face-to-face arm. But the middle 8 were 8 scheduled weekly telephone calls of up to 30 minutes in length. It was the same exact treatment as the face-to-face arm, but it was given in a shorter period of time, and the therapist sent the homework sheets to the patient. And then they monitored, in that respect, they kind of monitored their homework completion. As far as results go, one of the things they tell us in the study is that they analyzed the data on something called an intention to treat basis. Intention to treat basis means that when you analyze the data, you include everyone in the group or condition that they were initially assigned to. A helpful way to understand that is that in contrast, there's something called the per protocol basis. If you analyze according to the per protocol basis, then you only include in your analysis people who fully adhered to the treatment. So you would exclude people who did not complete their type of therapy. Or if they, for some reason, switched to the other condition, you would still include them in the initial, in intention to treat, you would still include them in the initial group. So per protocol, on the other hand, only includes those people in the analysis that fully adhered. That can be a problem bias-wise because then you are excluding people who don't finish, so you're not getting the evidence of people that are maybe not showing the improvement, though that data is getting dropped out of the study. So only people who finish it are being included. So there can be a bias involved in per protocol. So they tell us they used intention to treat basis. So when you look at those averages and we look at those results, those include people who did not complete their treatment. 72% of the Ps had what they called clinically relevant treatment. It was defined as clinically relevant if their Y-box decreased by 2 standard deviations. You can see that the telephone group, actually 77% of the telephone group showed clinically relevant treatment compared to 67% of the face-to-face group. Remember, the hypothesis was that there would be no meaningful difference, that outcomes would be similar in between the two groups. And as you can see, the difference in the Y-box score between the two groups at that 6-month check-in was negative 0.55. So there was not a big difference in Y-box score between the two groups. That is not, of course, saying that their Y-box only went down by negative 0.55. You're going to see some mean scores. Their Y-box definitely decreased by more than that, but this is the difference between them. One of the things they did was measure the blindness of the study. What they did was they asked the assessors at the 1-month follow-up, they asked them to guess the participants' treatment status. They had them guess and see if they felt that they could tell which status they had received, whether it was face-to-face or telephone. 9 of the 72 patients indirectly or directly revealed their treatment status somehow, but of the remaining ones, they guessed 56% right, and they guessed 44% incorrectly. So there's no reason to think really that they had figured out in any systematic way who was receiving which treatment. So we didn't have to worry about a bias from our assessors. There was no significant difference in the client satisfaction either. So it's not as if telephone worked, but they did not like it as much, or they liked it appreciably more. There was not a significant difference between them. So when we look at this one here, which is that's the final follow-up, because they only followed up to 6 months. They give us the adjusted mean difference of negative 0.55. Now, if you look at the difference, you're probably like, it looks like 0.9 is the difference. They tell us that they adjusted it based on the baseline BDI score and the baseline Y-box score and the site. They don't explain how they do that, though. I don't suspect you're going to be, I really can't imagine you'd be asked that. But for your numbers, I would memorize your 77 versus your 67, and then just, I guess, know that the difference between them at that final follow-up of 6 months was negative 0.55. So not a very big difference between them. It's also worth looking at, here's your BDI scores by the two groups, and then your client satisfaction. So like I said, it was right about 29 out of 32. Here too kind of visually shows it to us. They definitely showed an improvement at their, this is immediately after treatment, so immediately after their 10 weeks of treatment, and then that was mostly maintained, and this is the Y-box in particular. That was mostly maintained, and as you can see, they stay pretty close to each other, which was the point. The outcomes are similar. You can see that kind of similar trend happens in the Beck Depression Inventory. You can see the immediately after treatment. We do see that the telephone group is a little bit higher when it comes to BDI, but in the end, in the 6 months, there's not much difference there either. I'll let you pause and take a look at the strengths and the weaknesses. And then I'll just mention to you a few things of note from the discussion. They mentioned that sample size in our study is equal to or greater than most other studies of CBT in this disorder. The attrition rate or the dropout rate in our study was low compared with other studies, which contrasts with reports that patients with OCD often refuse that exposure treatment. Only one patient was lost from the telephone arm of the trial. Reasons for the low attrition rate in both treatment arms are unclear. Both clinics had long waiting lists of 12 months or more, so it is possible that the participants were all highly motivated. It's also possible that the experienced therapists who did this were particularly good at engaging the patients. They talk about the economic implications, and obviously if these clinics have 12-month waiting lists, there are people who obviously want to seek treatment. And the fact that those telephone sessions were 50% shorter than the face-to-face means that the same therapist can provide that therapy to more people. They acknowledge the limitation of not having a control group, but there was no difference in the two groups at the baseline. So in that respect, they can still be sure, because they both started at roughly a mean of 25. So they can be sure that it was the treatment that had some effect. They also mention the limitation that it is possible, obviously the short follow-up, they were only followed up for 6 months. So that precludes being able to draw conclusions about the long-term efficacy of telephone treatment versus face-to-face. It is possible that the efficacy would drop off more substantially in telephone treatment than in face-to-face, but this study just doesn't answer that because it doesn't have that follow-up. And also they acknowledge that their findings may only be relevant to settings where the patients are being treated by experienced therapists in departments that specialize in CBT. It is possible that, like they said, it's possible that those therapists were just very experienced and you would not see the same results if you had clinicians who were not as experienced with it.